Hello, budding surgeons. This is Dr.Sonkar. Today I'll be talking on a topic called laparoscopic suturing, the tips and tricks how to do a laparoscopic suturing. Tips for laparoscopic suturing. You remember three good T's. First T is tools. Understand the instrument which you are dealing, what needle holder, what is a needle holder, how does it function, and what are the various types of needle holder, and which needle holder suits you better. Second T is technique. So, to ease the process of laparoscopic suturing, you should follow proper ergonomics, proper port placement. This will decrease your stress and make the suturing a art. Third is your temperament. Remember, students, it is not a manual work, but it is skill work. What do you mean by a skill work? Skill work is actually work that is acquired with proper knowledge and practice. So repeated practice with proper technique will always help you, will improve your suturing skills. Now coming to the tools. First and foremost is you should have a good quality needle holder which you can get for a cheaper rate also. Around 10,000 is good enough to invest in a needle holder. You have up to 1 lakh 1 lakh rupees needle holder, but that is not needed. Preferably 10,000 needle holder is good enough. Second, what are the types of needle holder you can have? There are two types of needle holder you can have. One is piston grip type that was made by Ethicon, that is Johnson & Johnson, and second is coaxial or also called as storz type. So this is the type of piston grip type of needle holder in which the axis, long axis of the instrument is not in the line with your handle. So it is at the almost 70-degree angle with the long axis of the instrument. Whereas another type, that is the coaxial type or also called as inline needle holder, the long axis of the instrument and the handle are in the same line. Second is whether the tip is straight or curved. So curved tip is little better because it gives you a better vision. So this is an example of a straight tip needle holder, and this is an example of the curved tip needle holder. It depends on the surgeon preference which they want to use. Second thing is self-riding needle holder. There is something called a self-riding needle holder. It is the tip of the self-riding needle holder is like this. These are preferred by some users, some surgeons. The peculiarity of this needle holder is when you catch the needle holder, is automatically yourself rides the needle in a right angle to this instrument. So you don't have to manipulate the angle with the other hand. So you don't have to manipulate. Whereas in this, you have to auto correct with your left hand so that you can do a proper suturing. Problem with the self-riding needle holder is you cannot change the angle. So suturing at difficult positions or difficult angles is not possible with straight self-riding needle holder. Whereas with this type of needle holder, curved or a straight tip, you can angulate the needle with respect to your instrument and suture at difficult places. And the last one is good endovision system. At least HD or 4K is better recommended for a laparoscopic suturing. Suture preferences. Let me tell you about the anatomy of the needle. So this is the needle. This is called as the needle tip. This is called as the needle body. This is called as a swage end. When your suture is attached, it is called as a swage end. And this is the needle cord length. So normally 10 or 20 suture is preferably better for laparoscopic suturing, but if there are times where you may have to opt for a number 1 needle or even a smaller needle 30 at times, but this is the most commonly preferred needle sizes, suture sizes which we use in laparoscopic surgery. Second is preferably use half circle needle, and the length of the needle should be not more than 20 to 30 mm for a standard suturing or anastomosing the bowel or closing the peritoneum. Third is when you want to give a stitch over any one single stitch, then the ideal length is approximately 10 to 15 centimeter. A bigger suture than this may cause problem while suturing. But the maximum length of the suture that can be managed laparoscopically recommended is 25 to 30 centimeters. That means if you are doing a TAPP, you have to close the entire length of your peritoneal flap. Then 25 to 30 centimeter suture length is adequate enough. A suture beyond this length will cause problem, difficulty in manipulating inside the abdomen. Next, the material. What material should you use? So remember, you must be aware, less memory like Vicryl, silk, ethicon sutures are better preferred because they have less memory. And the sutures like proline, nylon, PDS have slightly more memory as compared to the Vicryl and silk, so they are less preferred. But when you are doing a hernia surgery, proline is preferred because it is a what do you call the permanent suture. Next type of suture is self-retaining locking suture, that is barb suture. They have come up a long way. They are basically better for laparoscopic suturing in case of a ventral hernia when you're closing the defect. So they become very handy because they are self-retaining. You don't have to pull. You don't have to keep constant traction. Once you pull, it stays there. Now, how do you enter with the needle or the suture inside the abdomen? There are various techniques. I'll describe three. First is the direct through the port. You insert the needle with the thread through the port. Second is indirectly feeding of the port. And third is direct puncture of the skin. So this is the way when you directly insert the needle, suture and the needle through the port. So you have to hold the suture 2-3 centimeter away from the swage end of the needle, and then place it through the port. Second indirect technique, when the needle is larger or you're not comfortable with passing the suture through the 10 mm, or you only have 5 mm what do you call the ports, then what you do, you remove the port, you pre-feed your needle holder through the port and catch the tip of the needle or the what you call the away from the swage end 2 centimeters, and then through the port you have already made, you enter, and under vision you enter inside the abdomen and you insert the needle and the suture. Third is, if you are dealing with a large needle, very long, number one needle, that is 40 mm needle, 35 mm needle, then you can directly puncture the skin and enter inside the abdomen. Now coming to the technique, the way you suture is very important because it is the most problematic part of this suturing. If you don't follow proper technique, then you always struggle and you differ from suturing laparoscopically. So the first and foremost important thing is basics of ergonomics. You should know proper basics of ergonomics. What is ergonomics? How it is important in suturing. Second is, you should be ambidextrous. That means both hands should be working simultaneously in synchronous manner. It does not mean you can suture with your right hand as well as your left hand, but both the hands of the surgeon should work in synchronous with each other, so that it will complement, your right hand movement will complement with the left hand movement. Third is, there are various types of suturing: the forehand suturing, the backhand suturing, or for that said single hand suturing. You can adopt any of this which suits you better. Next is slow and steady hand movements. You have to be very precise. Slow and steady hand movements should practice. Over the time, as you practice, your movement will become more faster. So initially you should stress over the technique, the way you suture, you way handle, to the angle at which you pierce the tissue. That should be slow and steady to develop a good technique. And lastly, the most important is practice, practice and practice. There is nothing better than practice. The repeated practice will make you perfect in suturing. Coming to ergonomics of laparoscopic suturing. So first important thing is straight line principle. What does the straight line principle mean? Straight line principle means the surgeon, the pathology and the monitor, all three should be in the straight line for a better ergonomic position and better suturing. Second is port placement. That is, you should have a contralateral port placement. Your camera should be in between your right and the left hand working instrument. Azimuth angle. Azimuth angle is the angle between the telescope and the one of the working instrument. So this is the azimuth angle. It should be ideally 30 degree, and two azimuth angle forms a manipulation angle. So the angle between the right hand working instrument and the angle between the left hand working instrument forms an angle that is called as manipulation angle, and it should be 60 degree for good laparoscopic suturing. There is something called as elevation angle. Elevation angle is an angle made by the patient's body with the instrument. So this is elevation angle. So you should have a 60 degree elevation angle that is equal to the manipulation angle for better suturing angles. The height of the table is also important while suturing, so that the angle should be more than 90 degree. elbow angle should be more than 90 degree. That is better or ergonomically better for suturing. And third is predominantly you make a pronation and supination movement with your hand. There is no right to left movement or up to down movement. The most predominant movement which you do for suturing is your pronation and supination movement. Now, suturing technique you divide into steps. The first is how do you hold the needle or load the needle onto the needle holder and drive through the tissue. So first part is you load the needle over the needle holder and drive through the tissue. Second is knotting. What configuration of knot you would like to have and how do you do a knotting. And third is tightening the knot or locking the knot properly. So first is needle hole loading. So there are three types of technique I would demonstrate in the video. First is deposit and pickup technique. Second is dangling pirouette technique, and third is two hand technique. So these are the three various techniques that through which you can handle a needle or load a needle over the needle holder. Holding needle should be at the junction of anterior 2/3 and 1/3. That is normally followed in an open case also. You should hold the needle at the tip at the right angle to the needle holder. You can appreciate the needle holder tip is used for holding the needle and it is approximately 2/3 and 1/3 of the distance and at the right angle to the needle holder. And third thing is the angle of penetration into the tissue should be 70 degree so that you have a better ergonomically better position. Knot tying. So you can have a choice of surgeons through a knot or a square knot or a slip knot, that is granny's knot. And there is something called as C and a reverse C pattern that I will demonstrate in the video. Third is tightening or locking the knot. You should hold close to the stitch line, I mean the sutures, and then or to tighten the knot and wait for the plastic deformation or the permanent deformation you can see in the tissue, and then you can release the tension. You can see here. So this is called as crying position of the needle. You take the needle. This is the fixed end. This is the mobile end of the needle holder. You keep near the needle and then you press over the tissue. Press over the tissue and then needle automatically rotates and get in position. It forms a right angle with the needle holder. This is the smiling position of the needle. Similarly, you can do with the smiling position also. You bring the needle holder and press over the tissue and then it will automatically direct itself in the right angle and you hold it with the tip of the needle holder. This is called as pick up and drop technique. Second technique is dangling pirouette technique. You fix the tip of the needle holder over the tissue, hold the suture 2 to 3 centimeter away from the swage end and rotate, and once you find the proper position to hold the needle, you angle the needle. So now you can do a suturing. This is third technique, that is the two hand technique, in which you can use the right and the left hand, and with the right and the left hand you can manipulate and adjust the angle and accordingly you can suture. Now the knot tying, how do you tie knot? So you enter the tissues into with the 70 degree of angulation, and with the help of the left hand you drag the suture and make a smaller end and a bigger end. So here it forms a C. Here it forms a C. So this is the smaller end, this is the bigger end. Now the left hand goes above the this loop and tip to tip maneuver and take two winds, and then you catch hold of the shorter end, and this will form a squaring of knot. Again you bring the longer end towards the left side of patient, and this will form a reverse C position of the suture, and then under wrap you go below this loop and then catch the suture and you form a what you call a square knot. This is a example of a square knot. So this is the way you tie the suture. Now Laparoscopic suturing in ventral hernias. So, laparoscopic suturing in ventral hernia is little different than the intracorporeal suturing, because you have to suture over the anterior abdominal wall, and the elevation angle is minimum in this because you are working over the roof. Just imagine how difficult it is to work over the roof. So, there are various techniques. First is intracorporeal technique, and the one is extracorporeal, also called as shoelace method. You can use a forehand technique, you can use a backhand technique, or a single-handed technique for suturing the anterior abdominal wall. Extracorporeal suturing. For extracorporeal suturing, you should have something called as suture passer. This is Bursey type of suture passer needle, and this is the port closure type of suture passer needle. This was initially devised to close the 10 mm port while doing a laparoscopic surgery, but it is been extended for closure of the defect extracorporeally. As you can see in the defect, we make a hole in this skin and pass the suture through the suture passer needle, and then we catch the suture inside, and again through the same hole we reintroduce the what you call the suture passer, but through a different facial opening, and recatch the suture, and this process is repeated multiple times from various places so that we close the defect. So this way you can close the entire defect, long defect, with less stress. You can see we make same one single skin incision, but we change the multiple facial incisions, and then recast the suture, and then close the defect in a shoelace pattern. This is example of single-handed knotting technique. If you don't have an additional port to hold the suture or take a what do you call the knot, then you can use your single-handed suturing. The prerequisite for this type of suturing, you should have a long length, at least 100 centimeter of suture. The other end is outside the abdomen. You manipulate it with your other hand, and your right hand you engulf the entire what you call the appendix, and then through the with one hand you manipulate so that you suture the base of the appendix comfortably. This technique becomes very handy when you have only one port, or you want doing it for a appendicular base, or for that sake cystic artery can also be ligated, cystic duct can also be ligated with this technique. I'm giving a counter traction with my left hand, which is holding the long end of the suture outside, so that the knot becomes tight. Now I'm cutting in between the two sutures. And the last T that is important is the temperament of the surgeon. Mind one thing, suturing is not a hard work, but surgeons hardly work on it. So if you work hard over suturing skills, then you can definitely improve your suturing skills. Open surgery suturing is easier, laparoscopic is difficult, but it can be overcome by repeated practice. Floor suturing is easy, the roof suturing is difficult. So you should always practice, practice, and practice on endotainers, or you can do practice suturing over when you're doing a laparoscopic cholecystectomy, appendicectomy. Rather than applying clips, you can practice suturing over these arteries and the ducts. Thank you for listening. Any questions can be asked in the comment section. Thank you.